Hi there. My name is Dr. Kimberly Ernest. I'm a licensed psychologist, licensed professional counselor, the president of Pennsylvania Counseling Services, the founder of Live Up Counseling. And today we are here to talk about IBHS services, what it means, who benefits, who qualifies, and who might be a good fit for a role in this type of position.
Hi, I'm Victoria Miller. I'm Senior Clinical Director of IBHS here at PA Counseling Services and a board-certified behavior analyst.
Hi, I'm Alicia Paxson. I'm a board-certified behavior analyst and also a clinical director for IBHS for Adams and Lancaster County.
Hi, I'm Sam Snyder. I'm also a board-certified behavior analyst and clinical director for Cumberland and Dauphin counties. I am Elise Nichols. I am the Intensive Behavioral Health Service Administrator for Dauphin and Lancaster County.
Perfect. So we are going to start out today with the 10,000 foot view. It's really important for me to note I haven't actually worked within the service for 21 years. So some things have probably changed. Definitely the name, probably some other things as well. But I prepared things a bit last minute. So y'all just call me out if I get anything wrong. Okay. It'll be a fun new way to start the How to Be Happy Hour. All right. So when we are talking about intensive behavioral health services, or IBHS, here in the state of Pennsylvania, and I limited my prep to just the state of Pennsylvania because each state, each location, probably even each county does things just a little bit differently. That was something that was really surprising to me. I was in IBHS back in the day called, I think it was Wraparound, way back when I was in it. And I was called a TSS. I know that job no longer exists. We now call them BHT ABAs. But when I moved from Pennsylvania to Texas and started to grad school down there, started to go to grad school down there, my plan, my due north was I'll just become a TSS down there. Well, they don't have them down there. This service doesn't even exist in the state of Texas. So today we're going to be talking about IBHS services in the state of Pennsylvania, and most specifically how it applies to Medicaid or MCO populations. I know private insurances also can fund this type of service. I also know here at PA Counseling, that's not really what we do. It's not to say that children and adolescents who have private insurance don't qualify. I'm just saying I'm not an expert on that. I'm not an expert on this either. But I definitely didn't want to take it that far in terms of what we talked about here today. So for the most part, we're going to be talking about Pennsylvania Medicaid populations when it comes to IBHS, with the recognition that that can look different in different states. It can look different with different funders, but that's sort of where I'm sticking with today. So we're also going to talk about how IBHS, which is a community-based support working in the homes, schools, and community settings, can serve children, adolescents, and their family systems or their natural supports in addressing all different kinds of things like emotional, behavioral, or developmental struggles. We're also going to talk a little bit about how to access these services, who to call or where to begin, and what next steps are appropriate if you believe this type of service would be useful or helpful to your family. And also we're going to go through sort of the role the parent, guardian, educator, if they're in a school system, or any other sort of natural supports can lean in to support the generalization of skills learned in IBHS and what that means next. So in order to obtain IBHS services, there's two key ways in which individuals can access it. The first is through a written order, which needs to come from a physician, psychologist, certified nurse practitioner, or another clinical license. And that written order will specify the type, amount, frequency, and duration of services. They can also access services through an evaluation. Sometimes those timelines take a little bit longer. So depending on your county, depending on your funding source, you can start out with a written order and move into an evaluation. Alternatively, you can also start out with an evaluation and use that to get a written order. I wish I could tell you more about how those different things work. When my own kiddo was looking for some services or some support, I think I called 9 different places before I was able to find somebody who took my insurance and kind of next steps, which is sort of the impetus behind this series of podcasts, really trying to demystify our levels of care. Then once you have a written order, you need to choose a licensed IBHS provider. And here in the state of Pennsylvania, you have provider choice. Also, in many of our counties, you have a bit of a lengthy wait list. So you might want to start with your funder and work backwards from there. See who has the shortest wait list. I know that our managed care companies often will keep their own wait lists. You can also sometimes, sort of depending on the county, I'm understanding this is different, so tell me if I'm wrong. But depending on the county, you might get on the wait list for the individual provider in addition to the MCO. So there's a lot of different wait lists you can throw your name on. And if you are really seeking services, my advice to any caregiver trying to navigate this system is to get their name on as many lists as possible, recognizing that sometimes it's unpredictable. We have staffing challenges, we have turnover, we have random hires that crawl out of the woodwork, and suddenly availability will shift and change there. So while it might be discouraging or exhausting to really call and get yourself, diversify your options in that space, I believe is wise. Then once that name comes up on that wait list, and you've chosen a provider, you then collaborate with that provider to get an individualized treatment plan to address that child's needs and make sure that the services in place are really conducive to what that child needs, as well as what your environment needs. So if the child's struggling in a school setting, ideally the services would be designed to address school-based behavior. Alternatively, if the child's having a lot of trouble in the home setting, maybe that's where we get some extra help. Maybe it's on the school bus, as all great behaviors are known to emerge. Maybe it's in the afternoon in those after school hours. So really designing the treatment plan or that initial individualized service plan to address where the behaviors are most problematic, and then go from there. So who qualifies? IBHS in the state of Pennsylvania is to support children, youth, and adolescents, young adults up to the age of 21 with a behavioral health diagnosis. These services are not limited to a specific diagnosis, but are available across various behavioral health conditions, which may include autism spectrum disorder, attention deficit hyperactivity disorder, anxiety disorders, depressive disorders, oppositional defiant disorders, or conduct-based disorders. The primary criterion for IBHS eligibility is the presence of a behavioral health diagnosis that necessitates intensive behavioral interventions. And this can be determined by a licensed professional within the child's worldview to provide that written order or make that recommendation. That behavioral health diagnosis can be based on the DSM or the ICD-10. And the recommendation should look at the type, amount, and frequency of the service based on the intensity of need of the child. So ideally, the child might be better served in a lower level of care. And if so, we want to go with that least restrictive service to begin with. But oftentimes, as with any of the levels of care, we might notice children start out at a lower level of care and require a higher level of care, start out at a higher level of care and titrate down to a lower level of care. So they can move back and forth between outpatient, med management, IBHS, or even family-based, or sometimes even a more intense service like hospitalization or RTF, though hopefully we avoid those. Now, when it comes to IBHS, there are a couple of different ways in which services can be administered. They can be done in an individual one-on-one setting. We can also do it within a group setting, though that's something that we do a lot less of here at PA Counseling. There are also like 3 key positions with an IBHS. So you have your BCBA, which I have the gift of having a couple of y'all around the table here today. You also have your BCMT, which can provide sort of guidance for whatever the plan is, work with the family, work with the caregivers, work with the school systems, gather some data, right? It's a very data-driven service. Gather the data, develop a plan. And then we also have the BHTABAs. I wish I could tell you what that stood for. Behavioral health clinician. Technician. Behavioral health technician, ABA, applied behavioral analysis. Okay, there we go. So that's your one-on-one. A BHTABA typically is a non-degreed individual or somebody with a bachelor's degree that sort of takes that plan, does a little data collection as well along the way, and supports the implementation of that plan with a more intensive way. There are also additional roles that may or may not be involved at different points in time. So you might have case management involved, education consultants, sometimes even family peer support specialists can get involved, or like family advocates. There's a lot of different other ancillary community partners that can be involved as well. We also are home-based, so we try to address behaviors within the home, school-based, try to support students and educators in managing behaviors within the school setting, and then implement those strategies when we're gone, and community-based settings. At the end of the day, what we are driving towards is generalizing these skills so that we can step out, and the natural supports can continue to manage these behaviors. And IBHS can work and help in a variety of different ways. So we can support when it comes to aggressive, disruptive, or self-harming behaviors and encourage positive behaviors within a setting. We can support parents and caregivers, but ultimately the child, in identifying coping strategies to implement and utilize to avoid anger or frustration driving the bus when behaviors get really out of line. We can also support in skill development when it comes to social skills and figuring out sort of how to make friends, sharing, taking turns, role-playing scenarios. Ultimately, we can support children and adolescents in being successful in a school setting so that attention, focus, and behaviors are not impeding their ability to learn. Support communication skills, support caregivers in navigating challenging behaviors most effectively. We're driving towards that self-care and independence, teaching transitional skills, and then ultimately, if we're present within the setting when a crisis were emerge, we can support in the de-escalation of those crisis behaviors. Shoo! Well, I just had a mouthful. What did I miss? What did I get wrong? Is there anything from y'all's perspective that you think would be really important for either a caregiver about to start this service or wondering if this service is right for them, a prospective candidate, either a master's or bachelor's level or even non-degreed staff member that's kind of like, I might want to work in this field, and I hear non-degree, that's interesting to me, anything they might need to know, or ultimately like a potential referral source, like a school system, a karate teacher, I don't know, a bus driver who might refer to this service. What would people need to know from y'all's perspective that could be useful or helpful to those watching this podcast?
I think if we look for the families, you talked about how, we really create that individualized treatment plan. But part of that now with IBHS is we have, depends on the service, we have individual services, which is the BCMT, BHT, or the ABA services, which is the BA, BCBA, and BHT ABA. But they each have their own specific assessment period. So one is 15 days, one is 30 days. And in that assessment period, it's really the clinician, the master's level clinician, gets in there to really determine what behaviors are going on, where do we need to be at. And that's a really good place to figure out, like, do we need a higher level of care? So sometimes we get in there, we're like, oh my goodness, this is way more than IBHS can help with at this time. And we kind of help transition them to that. Or we've also had some, even recently, we've had a few where we're not the right level of care. They kind of just need a case manager. So we get them set up with that and help them along the way. So they can initiate the services and we can go over it with the family and say, okay, so you're prescribed 100 hours a month. What does that look like? So breaking that down, because 100 hours a month is a lot, but in grand scheme of things isn't. Like, it just kind of depends. So if you need a kid that needs all day staffing, 100 hours won't do that. That's 25 hours a week. So, but if you need a kid that only needs help maybe 2 nights a week at like karate, 100 hours is way too much. So it's a great time to get together with the family and really talk about where you see the need. Does this match what you need, but also, is this feasible for your family? Because it is a voluntary service. So that's one really good thing about IBHS, since we transitioned from the BHS world, is we have that time period. And even while we open, after the assessment, we officially open and have an authorization, they can still continuously assess. And, we have an assessment document and some other things. So like they can continue to do that. And I think it's more, not that we didn't do it in the BHS world, we did. But I think now there's definitely more of a process to help with that, to really make sure people are getting the right level of care and we are providing the right level of support to each family. So I would say for the families, that's probably the most important thing. Now, to answer your question about when you get into this field, if you're interested in this, I think everyone at this table started as a TSS. So, yeah. So I was going to say, I think I was an MTBC by the time you guys came around, but I was a TSS under Victoria. Yeah.
As everyone's supervisor, maybe except yours, really directly.
Yeah.
For a little, not often.
Yeah.
So, I mean, I'm not going to lie, when I started here a very long time ago, out of college, I loved little kids. So I was like, I just want to work with kids. And 22-year-old me didn't realize I'd be here 16 years later doing other things. But it was a great way to get in and determine, like, is this something you really want to do? And I think it helps you figure out, do you like I love the early intervention, young kiddos, lower functioning. They were my favorite. So you get to figure out kind of like, what clients do you prefer more? What type of diagnoses do you prefer more? Do you prefer the ODD kids? When I was first out of college, if you would have given me an ODD kid, I would have ran the other way. Now, no, that's a different story. But back then, yes. And even the first time that my MTBC took me out to my first kid, he used to line up cars. And she's like, you need to move that. And I said, absolutely not. He's going to cry. I'm not doing that. And I felt so badly. And I had to get over, like, I'm not physically hurting this child. Like, I'm just, in order to interact and teach him things, like, we got to shake up his little world a little bit. And if that means moving his car a tiny bit, that's okay. I didn't hurt him. It was upsetting. We worked through it together at that time. So, like, I think it's a really great place to start as a BHT, to figure out, do you like the clientele? Do you like kids? Do you like a certain age range of kids? Because we do have some little guys. We have some 3-year-olds. We also have, I think your client's 20? Almost 20. Right. So we have a wide range of ages, a wide range of diagnoses. So you can really tell, like, is this something you want to do? But also, do you want to be in a school? Do you want to be in a daycare? Do you want to be in clients' homes? So I think it's a really great thing if you're coming even out of high school into college, trying to figure out where is that niche that you want to be. It's a great jumping off point.
And I will say, and I'm probably the only person around this table that took kind of a hard left after TSS. I went from that to working with justice-involved individuals with problematic sexual behaviors. So, though I will say, every single thing that I learned as a TSS and all of those behavioral principles and some of that foundational stuff, I've used the rest of my career all the time. And even if it's not in the same way, like, I don't do like functional assessments anymore, or functional behavioral assessments anymore. But if I'm doing psychotherapy with a client who is just shooting the shit and talking about the weather and not showing up to do therapeutic work in that moment, I use my body as the reinforcer, and I like lean back and I look disinterested and I check my nails or whatever. And then when they start to like get into the meat of the therapeutic work, I lean in and I'm more interested and I show up differently. And so all of those different things that, like, yeah, it doesn't translate perfectly, but a lot of those same like rules and principles have served me the rest of my career. Plus I have dogs, so it helps with that too.
Yeah, spouses. It works very well with spouses. I always get told, stop using planned ignoring, because I do that a lot, or I put things on extinction. So it's effective though. So it is something that helps. You can help figure you out where you want to go clinically and career-wise, but also it's a lot of valuable skills to just take with you everywhere.
I think being a BHT is a great stepping stone. A lot of people don't want to stay there forever and make it their career, but whether or not you want to go to clinician, most people in PCS, well, we have so many different positions to offer outside of behavioral health. So maybe not most, but a lot of folks in PCS started out as a BHT, and maybe they're now into like outpatient or family-based or drug and alcohol. And so it's kind of neat to see that starting knowledge. And I agree, it helps you. It helps me as a parent. It helps me as a clinician. It helps me as a supervisor. And I'm grateful for that. And it also like is often trial by fire. So if you can handle being like a BHT for like an aggressive kid or a runner or someone who's really going to challenge you, I think it develops some of the grit and toughness that will serve you well in a variety of other jobs. I wanted to say with the assessment phase that Elise was talking about, there's some downsides to it. It is a lot of work, but it does enable us to more appropriately recommend. Like before, it was just here's what the evaluator said. And if we did want to change it, it was like a back and forth process. And sometimes if we didn't do the eval, it was very hard to get that changed. So we'd have like kids with minimal problems getting like 30 hours a week and we're just bodies there. Now we can be a little more intentional with that. And like she said, if it's a kid who just needs some home sessions, we can do that. If they need all day support, we can do that. But it's a little more efficient in the sense of, hey, if they don't need us, then we make the referral, try to connect them with those resources. So that's something new. And then you did touch on it, but what popped into my head was another change for IBHS was a broader latitude to do skill building. So in BHRS, we always got crap if we had goals that were like for activities of daily living or self-help skills, or even just like building language. It's a kid, it's one of those unicorns who they don't have a lot of behaviors, but they're not talking and they're sitting in the corner stimming with not a lot of other externalizing issues. But now we have a lot more room for like the more intensive programming. So your discrete child instruction, verbal behavior, and different programs like that. So it's kind of nice not to feel like we have to like over justify that. We can just go in saying, here's what we're doing, here's the program goals, and make those actual treatment plan goals. We don't have to disguise them as compliance or something else.
Yeah, and I think within the IBHS world, it's so individualized. And when we're doing those assessment pieces, looking at the environment, I know you spoke to like doing an FBA, looking at the environment. I think a lot of people, when they open with us, assume we're here to come in and fix the kid. We're here to come in and work with the kid only. But we really look at the environment as a whole and how we can shift that environment for that client to be successful. And we can use that assessment time to help figure out what is going to be successful for that client, whether it is ABA or something different, a different level of care. So I just love that, especially at PCS, we really take that individualized approach to treatment and making sure that that individualized treatment is written, a treatment plan is written for them, specifically that client, and no two treatment plans should look exactly the same.
If you are like a caregiver that is just starting out and kind of looking at this through fresh eyes, what would you all say would be things that a parent, my youngest, for example, or I used the example before we were filming, that we had some trouble with some bus-related behaviors. And so in an effort to not get him kicked off the bus, I scrambled to make sure he had an eval and some recommendations and some next steps. And luckily, all those different pieces kind of fell into place and we were able to figure things out. But I'm a caregiver that's been in this field for 20 some years, and at least knew where to begin. And what really struck me was how many places I needed to call, how many closed doors I met along the way, some of those different challenges. And so let's say that you're a caregiver of a kiddo with like autism spectrum disorder or ADHD, and you know that you're going to need a higher level of care than that more traditional outpatient setting. What would be the first step that y'all would suggest? And what can a caregiver expect in that early season of support seeking? Because I suspect if it were me, not knowing what was out there, I would have been kind of discouraged and maybe had cut my losses at a certain point. But I was like, no, I know what I can get. I'm going to find it until I get there. So I had that unique perspective. But I would be heartbroken if a caregiver after call 2 or 3 is like, well, I guess no one can help me, because you really can. It's just finding the right spot. So what can caregivers expect?
I would say starting with their insurance company first and asking. So if they have no other resources, insurance company is a good start, just because they can kind of point you in the right direction, tell you what the process would be. You can ask them for what are some referral sources, some agencies, but also primary care doctors also are a good resource sometimes. Some are better than others, but they do have a lot of really good supports. I hate to say this, but social media can also be a good thing. It's caveat, not always. There's a lot of fads and some little scary stuff you can get into, but there are some good support groups on like Facebook. There are a few families actually that I follow on TikTok that are ABA families, and so they talk about things. Even, and I know this is hard because as an administrator, when I get, referrals and I have to call and say, hey, like we got your referral, it's a 12 to 18 month wait. It's not a great thing for me to have to call and say, and I feel so badly to have to do that. But I give them the option. So I say, listen, I can hold your stuff here regardless, and I'll keep you on our list, but here's some other steps you can do. So here's some other providers. Sometimes there's other providers that may have a little bit more flexibility than we do, just with their staffing, go on the insurance wait list. So I give them other options. So I think that's also important for parents is to, when someone just closes the door on you, so technically, yes, it is me closing a door when I say it's 12 to 18 months. Mm-hmm. It is. But if someone says, hey, do you have other suggestions for me? Absolutely. I will load you up with suggestions. And even, they can keep calling me back every week. I'm unfortunately probably not going to have a different answer for them. But they're more than welcome to do that. So I think not being afraid to ask. And if someone just says no, ask, well, what else is there? Mm-hmm. So some people may not want to provide that, but you will find someone that will say, here's some other options for you.
Mm-hmm. Even going back a little further than that, what insurance? Like if you're with us, you need to have MA. If you're not, there are now a lot of agencies that do like ABA only, and they'll only take private. So there is an avenue for that. There's a lot more. I think when we used to do the provider of choice, when I started, there was maybe like 5 providers. Like, what are we up to? Maybe about 15?
Oh my goodness.
More in Dauphin anyway.
In Dauphin, way over.
Way more? That's great. So there are options. It's just the demand's also risen. Then it goes to diagnosis. So I do evaluations also. And some parents will say, I don't want my kid to be labeled. I'm like, well, unfortunately, to get the service, we need something. Whether it's something that sounds more transient, like an adjustment disorder, or it's like autism, something that's likely to stick with you for a long time. It's just, I emphasize, like, it's a means to get service. It doesn't mean we're necessarily, like Sam said, with individualization, we don't have like the ADHD treatment plan or the autism treatment plan. We're just looking at what's actually happening with them and then making that. But a lot of times that's even a process for parents, like to get MA, then to get in with like a developmental pediatrician or a psychologist or someone who can make a diagnosis that's within the realm of those that we serve is often a waiting game too. So if the kid has verbal skills, they might be able to do like outpatient until they can get us, but we also know a subset of our population is not able to do that. There could be possibilities with like play therapy or PCIT at times, but again, not usually a plethora of openings or people that specialize there. So that's probably some of the other referrals Elise has or can make to outlets like that. But demand is unfortunately outweighing supply at this point.
Do different diagnoses. One of the things that I noticed when I was calling for my little guy is that sometimes they would say things like, are you sure he's not autistic? Like, are you sure he's not demonstrating any signs of and I got the sense that resources may be more forthcoming if he fell into a different diagnostic category. And as somebody myself who's diagnosed with ADHD at 6, like, yeah, no, I'm sure. I'm certain what box he falls into, if we all, fit into a box. But I did think that was interesting, and I found myself feeling, and I've been curious about that ever since, that like, had he been on the autism spectrum, would I have only had to call 6 different places, because by then they would have had resources for him? Or does your diagnosis maybe allow different things, or was that just kind of something shady that I probably shouldn't bring up on the air?
No, I don't think it's shady. I think there's a few different answers to that.
Yes. Yeah.
Yes. I think there's a few different answers. I think one is, so if someone's calling me right off the bat and saying, hey, my kid has autism, I would like to get them treatment. My wait list for an ABA kid with autism, because of the state regulations and needing to be licensed and everything, that's going to be different. So case in point, in Dauphin right now, I have one clinician who is not licensed, so she cannot take ABA services. So if someone would come and say, I get a referral and it's for an ADHD kiddo, we can open you next week.
Okay.
But if it's autism, I can't. However, there's also other agencies, especially there's a lot in Dauphin, that their bread and butter is pretty much autism and ABA. And so it's not to say that that's all they take. That's just kind of their niche. So
I think there's more options for autism.
Yeah.
Like, that as a diagnosis gives you quicker access and more resources as a whole, but it doesn't mean that diagnosis to have IBHS or similar support.
It's ironic because it's a diagnosis that I suspect most caregivers have a really hard time with. Like, I would suspect, like, as a parent myself and just in working with other parents over the years, I would suspect that diagnosis lands hard in comparison to some of the others, I would suppose. And yet it does seem to be tied to the greatest amount of access to resources. So it's kind of paradoxical there.
I think they're kind of related because with autism, it is pervasive. So we know that there's going to be difficulties usually that will follow that individual, so that with that, they require sometimes a higher level of hours, and they tend to get recommended for higher levels because of that. So that's what I tend to see, at least in my history with autism. I feel like they do tend to get recommended higher level of, I don't want to say care, it's not the right word.
Support, higher intensity,
Yeah.
less questioning from managed care and insurance about autism because of the pervasive nature.
And I think because there's research there to support that. There's a lot of research with ABA and autism specifically. Now, we know there's a lot of research with ABA and a lot of other diagnoses and populations and such, but that's what they tend to focus on. So because it's pervasive, the difficulties will continue. And I think because of the research, they tend to get higher intensity or level of support generally, but I wouldn't say that's across the board. But I'm not an evaluator. I know you guys have.
Yeah, it's curious to me if you felt like they seem to be pushing it or like really wanting to know. I mean, there's different funding streams also, kind of how there's like ID, funding stream for that. But like I'm saying, autism, even in BHRS, I felt like we rarely would get questioned about it. All the hours would be approved. Meanwhile, there's the ODD kid where we've asked for like 30 hours and like, we'll approve 22. Like, just a random, like, to kind of fight and cut back where they could. But autism is like, we want 40 hours a week. They're like, okay. But the other nice thing about IBHS is that we do have a year off, which is different. We used to have 3, 4, 6 month offs, which were awful, and we would never get done doing paperwork. So we do have longer now for the off. We can assess whenever we want, or when they, client or caregivers request, or there's changes. But in some ways, having autism might delay your access to services, but you might get more hours when you do get services.
Right. I think with the emotional piece at intake, I always tell my family is like, we treat the behaviors, not the label. So if you can remove the label out of it and just look at what are the behaviors we need to treat to create the goals for the treatment plan, that makes that a less emotionally hard impact.
But I do find that the parents, especially when the diagnosis is new, I feel like when they come to us, a lot of times they're looking for answers, or they're looking for us to like give them everything. And I find as a clinician, especially starting out, like, 7 years ago when I was brand new, I was like, I need to have all these answers. I need to have everything figured out to tell these families. And I've learned over the years that this is a lifelong diagnosis. And with that will come questions throughout treatment, whether we're a part of it the entire time or not. But when the parents are coming in, especially if they're new to that diagnosis, I always try to impress upon them that they are the greatest advocates for their kids because they got here, because they got that service. They did the intake with us because we know all the hoops that they have to jump through before intake and all the pieces that they've had to already take place and already done. So I think just really trying to empower and make sure that they know they've already done what's needed to be done, and the rest will come. Those answers will come that they're looking for. But I think at least advocating or stressing the advocacy piece and how important that is.
When you think about, like, from that caregiver's perspective, what that, let's say they get the eval, they have a written order, they have a solid diagnosis, IBHS is in their future. Y'all mentioned that that they come up on the wait list, they get staffed. What are those expectations for those early weeks? How can they anticipate and understand who all will be in their home? And what is the expectation for, like, the method and frequency of communication they receive surrounding that season? Like, can they, I was just talking to one of my supervisees the other day, and she's like, I have a caregiver that after every single meeting wants like a 30-minute meeting after the meeting to like update on the progress. And what I'm trying to say is, like, that's not a part of the survey. Like, we're not doing that. But sort of what would be the expectation, or realizing that every organization is going to do things differently. But in general, what are kind of the rules of thumb for caregivers in that early season of IBHS involvement?
I like to review as a whole that the beginning is observation and data collection. We're not necessarily, similar to Sam, intervening right off the bat. So the behavior is not going to go away in a couple of days. It's also going to look like we're not doing anything if we're just kind of collecting information and sitting in the back versus helping with safety. And I think, like, depending on what you observe while you're present, you can intervene if you need to and be that assistance. But it's also important for parents or caregivers to understand we have to, like, gather all the info first.
I bet that's tough, like, for y'all as humans. And then I would suspect for the other folks in the room, like, if I've been on this wait list for 18 months and y'all show up and I'm like, what are you doing? I mean, I would suspect that there are moments where that would land hard, but truly it's your role in those early days to be kind of as unintrusive as possible, fly on the wall, if you will, gather the data so that you can be intentional about your interventions.
Yeah, when you're collecting data for the functional behavior assessment, we need to understand what happens right before the behavior and right after to help guide those treatment decisions.
And without us intervening. And I know that can be frustrating for the families to not have us jump in to save the day. But I also don't want them to get in the habit of thinking that's what we do. We jump in and save the day. Ultimately, this is a service that does require parent participation or whatever natural support we're working with in order to be successful. We will not be successful if it's just us intervening. So I do think that's an important part for them to learn and help, for us as clinicians to help to explain what that process looks like, that unbiased data collection, like you were saying. And then part of it is us coaching and sitting back and allowing them to intervene down the road when they're ready for those pieces.
What would you say is, like, the number one predictor of success in this particular type of service? Victoria.
Well, I want to back up just one question, then that one, I have some thoughts. But I've actually gotten feedback that the assessment phase is validating for parents because a lot of them feel very alone in experiencing some of the problems that they're having with their child. The behaviors, are in some cases life-altering, where parents have, like, had to quit jobs, or they got fired, or they have to now drive their kid to school every day, or they've had to change placements. So to have someone come in who is, like, non-judgmental and really just like, oh yeah, it makes perfect sense to me why they're doing that. Like, it's their way to communicate, or it's their way to get attention. And they sometimes really appreciate that. Like, now someone else sees what I go through on a daily basis versus, like, parents have shared, even during evals, like the school just judges me, like they think, I'm a bad mom because my kid's having these problems at school, but I'm not there. And I'm like, I get it. You're preaching to the choir. So I think the assessment helps sometimes for that, while it could be frustrating too that we're not jumping in. I think sometimes they're like, someone now knows what I'm going through. And the focus isn't like on, why don't you get a bedtime routine, or why don't you, it's like, no, we'll help you get a bedtime routine, or we'll help you like ignore that one thing that they do that you can't stand and give you other strategies versus just critiquing. So there's that. In terms of the biggest factor, I think, for success in IBHS in our service is engagement, whether that would be schools, families, community supports. A lot of times it's extended family where we'll have, even grandparents raising the kids or involved in caregiving. Whoever's significant in the kid's life is going to kind of need to do the things and participate. And that doesn't mean it's us coming in and like, here's your list of things to do. You have to do them. I think a lot of our staff are pretty flexible in meeting folks in the middle, because we always have like great ideas on paper, or like in a perfect world, this plan would fix everything. But then it's like the teacher can't give stickers out every 2 minutes to the whole class. Like, that's not doable. What can we do? That's where we kind of try to figure out, like, our own system combined with the school system, collaboration. Parents can't be on their phones for the whole sessions as much as they want or need some break sometimes. Like, we need them to be involved in the sessions at least a little bit, or we kind of use behavioral skills training. Like, we explain it, we show them, we have them do it. Same thing with the school staff. But my famous quote, and I'll give Dr. Fox credit, Richard Fox, one of my grad school professors, is a lot of what we do in ABA is very simple. We're looking at changing human behavior, which is a complex thing. But in terms of our protocols, our interventions, they're very simple. So that's like only 10% of the problem, is knowing what to do. We do our FBA, we have these ideas, write them up, write the treatment plan. The 90% is getting people to do it. It's extremely difficult to get people to even ignore a crying child because the child wanted a piece of candy and they were told no. Not only not giving them the piece of candy, but like not reasoning with them or talking to them or telling them to stop crying or looking at them. And it's just that one behavior, but it's really hard when you're like, don't feel well. You've worked a 10-hour day, you're hungry, you're tired, like all the real life factors, is kind of what we go up against. So it's really what we're proposing is often pretty simple, usable interventions. But then it's the working in between, like, well, if mom's not able to ignore, what else can we do? It's getting there, getting people to do the things. But sometimes it's, we can't just focus on doing the thing. We're like, well, we got to do a different thing, or we have to tweak the thing. And that's always like a personal flex I need to work on, is like the flexibility and how do I go off my usual. But I think our staff are very good at that and really do try to meet people in the middle. We move, but we need everyone else to move too. If we can meet in the middle, it's less for everyone, but it's best for the kid too. We see the best outcomes. I mean, with sometimes with great engagement, it's still slow progress. But we need it to even have any gains. I'm sure everyone has many, many stories of heartbreak of kids who needed a lot of help and they didn't have the engagement of the system. And those are the ones that, burn us out sometimes and we don't feel good about. But then we have great stories of success and progress. And it looks different for everybody, but it's because the caregivers were there, the school was showing up for the kid. And that's what keeps us in the field and in the job.
What would you say if I was a caregiver just starting out with my child? What's the expectation surrounding when I can start to see behavioral change, or what does a typical course of treatment, realizing there is no typical course, right? But what what would be sort of some of the expectations for a caregiver to have surrounding some of those non-preferred behaviors early in treatment?
I don't have a timeline per se.
Session 2.
Yeah. I walk in and it gets better.
Yep.
That'd be great. I don't have a timeline per se, but I think all of us know the classic line, things get better before they get worse generally. And I know that's opposite.
Yeah.
Sorry, guys. Things get worse before they get better. I was like, wait, what did I actually say? Things get worse before they get better. So I think that's usually in our treatment plans to help prepare all our natural supports. We tell our staff that. We tell ourselves that at times because we need those reminders. But generally, when you're going in and making a change in an environment, you're going to see that client react to that change and the natural supports react to that change. And it doesn't always look like it's getting better initially. In fact, sometimes it looks worse. You know, it looks like a regression initially. But I usually try to warn my families that that's a normal part of the process as we're figuring out what works for your child and as they learn and test boundaries as we implement new things. So I think generally, yes, it's going to vary based on each client and their, what behaviors they're presenting, how they respond to those interventions, and how those natural supports also respond to us and if they can be consistent. But I would generally say I'd expect a little bit, of a regression before we actually see improvement overall.
So it brings up the thought too of another really useful characteristics for caregivers is having, it's not high, like decent frustration tolerance, because that is a reality. And I will often say too, like, hey, if you're seeing that burst, it actually means you're doing the right thing. It means you're getting at the right thing. And through data and other, ways we can reassure them, like, okay, we should start to see this kind of come down now. But frustration tolerance is like a necessary skill, but that becomes really hairy because we know a lot of our caregivers have like their own trauma and their own problems in coping. And so that becomes difficult where we are there for the kid mostly, but then we have to do work with the caregivers or the schools in that area too, because behavior change is like rarely stress or challenge free. I don't know. Everyone can probably validate that, whether you're looking to like change your eating habits or exercise or be more, positive with a significant other. Like that's all hard things to do on a daily basis. But frustration tolerance would be another one that I would say if there was some magic way to teach it, it would be a very useful skill for IBHS.
What would you all say is sort of the biggest strength of the IBHS model when it comes to the folks working within it, the families that are served by it, or even the systems where these services take place? Where do you see some of the highlights of this model kind of play out most effectively?
I think in those school settings, if you have a teacher that's really engaged in a school team as a whole, if the child has an IEP or a 504 plan that's collaborative in those behavioral interventions, often that can really take off if once they're taught to the other natural supports, can they implement them alone in the classroom?
I think the big strength of our BHS is that it's in vivo, right? We go to where the client is and they don't have to present in an hour of outpatient in a certain way. We see them in all lights across all settings, hopefully, and we're able to really support and help across all settings as well. So I think the in vivo piece is so important of IBHS, and I'm probably a little biased, but I like the supervision piece that we have within IBHS as well, and the breakdown of support with BHT to MTBC to clinical director. So I think there's a good ring of support as well. There's always somebody to go to in addition to the admin. They should also be in there. They're also a great support. So I think there's always somebody to go to, whether you're BHT, a BC, or clinical director, you don't know what to do. There's always somebody to go to as well.
Yeah, I would definitely, I agree with you about the supervision pieces. I think for the BCs, they have it twice a month now, supervision, just for like BC supervision. They also have MT. But I feel like it's more targeted than it used to be back when I was an MT BC, which was a very long time ago. So I think it's more targeted, more specific, but they also now have a staff training plan too. So each clinician has some goals that they're working on and we're trying to enhance throughout the year. So I think it's a really great transition for our clients and who we serve. But I also think on the back end, our staff, I think, have almost gotten, I don't want to say better support, but maybe we've tailored our support more individualized to our staff to really help them succeed more, I think.
I think generally it's more intentional.
Yes.
It was more accidental before, and now it's an intentional plan to make sure the staff are also feeling like they have room to grow and more support.
Any challenges of IBHS, or what from y'all's perspectives are the big ones? What are the hardest parts of the work?
Staffing.
Yeah. Yes. Staffing is absolutely difficult. I would also say the waitlists and timelines. So it's, yes, waitlists to get to us in service, but also when we have a family that we're struggling to meet their needs in IBHS and we still want to be there and provide support and transition to that next level of care, that's still a difficult thing to do sometimes because we're not the only one with wait lists. Now, luckily, knock on wood, usually those other wait lists are not 18 months long. They're maybe like 2 or 3 months. But when you have a family that's in crisis, behaviors are really escalating, the family is in need of more support, that can be really challenging. I also think sometimes we do have some tough kiddos who it can be challenging, and it can, you know, staff that are BHTs that are in there every day and really kind of working on the ground level, implementing those interventions, can sometimes struggle and have rough days. And so I think for them, that's probably the worst. I think for me as an admin, it's either A, being that one to call and say, sorry, we have a long wait list, but also like when I have Sam or Alicia come to me and say, hey, listen, like I think this kid needs a higher level of care, we're in agreement, but what that transition plan looks like and why we would love it to be immediate. It's like, how can we provide the appropriate support while we get them what is actually clinically appropriate is also very difficult, I think.
And I think too, something that like really hits home for me, I have experience with kids with like comorbid medical diagnoses or like severe deficits. So that long-term plan's different. That long-term plan may not be to, you know, discharge just to the family, but maybe we set them up with home health care or something that's a more permanent support, because maybe the behaviors won't permanently go away. But if we can teach everyone else the skills and how to work with the child and implement them, then the family doesn't lose the support, right? They just swap out the BHT hands for the home health care hands, and then long term they have a better solution than being alone.
I think the challenge is going to vary depending on, you know, setting, kid, and everything like that. But I think sometimes it is the challenge of managing a behavior with the client. And we've all been there, I think, where we feel like, oh gosh, what's being thrown my way? What am I supposed to do about this situation? As a BHT or TSS back in the day, or as a BC. But I also think, I looked at this table. I was like, this is such a nice table. Oh, let's get that one for your store. Right. I know. I kept thinking that too. Oh, that's my train of thought. I'll come back to it.
Well, one thing that made me think that you were saying, and I know one case in particular, is when you either have opposing views of a child's behavior, or they view us as the solution. Like, oh, well, he lost his BHT and that's why he's having all these issues, versus like, but you're not putting anything in place to like help this kid. We alone are not the answer to that. But I think of staffing, and then with that, retention, because, you know, it is a difficult field. Changing behavior is hard. And I think at least at the clinician level, in BHRS, I would have said give it 6 months at least. Now I would say give it a year at least, because there are so many more rules and deadlines. And I think just to learn those I don't know that you can make an accurate assessment of like, is this for me or do I like this? Sometimes we know when it's definitely not for you, like earlier. But I think, if clinicians have the luxury and the patience, if they can give themselves time to really see, because it's almost always rough to start. That's normal. We always say like, hey, if you don't feel overwhelmed, I'd probably be a little more worried than if you're like, oh my gosh, I don't know what I'm doing or this is so much. I'm like, yep, it absolutely is. But yeah, I didn't want to steal that, but
Dead right. That's exactly where I was going. It's like the collaboration piece is where I was kind of going with that. And you don't want to feel like you're in it alone and that you're working harder than anybody else ultimately. So when that's happening, that's a red flag to me because I'm an overfunctioner. I'm like, let me pick up all the pieces. And when I start to do that, I recognize that something is going wrong within this case, in this system. So I think that collaboration piece or lack thereof sometimes can be a challenge for IBHS staff, whether it's that or the client piece, I think just will depend. But I think ultimately for me as a staff person, I will come back to my kids every day. It's the adults in their life sometimes that are the challenge for me at times and the lack of follow through.
Is there anything that y'all would see as useful or valuable for our referral sources, or even if they're not the referral source, like the other adult involved within the space in which you're working? So we've talked a lot about caregivers. There have been a lot of references to like, well, if I have a really great and involved teacher or some of those pieces, but ultimately, I think the thing that stands out to me about IBHS is how collaborative the service is. And I'm not sure that that is the expectation of the broader system at large. So like I can recall way back when I was a TSS and I would have a teacher come to me and like, hey, so can you watch my class so I can go to the bathroom? It's like, hey, no, that's not my job. Like, that's not my role. I'm here with this child. None of these other children are my responsibility. And even him, I'm not here to watch him or babysit him. Like, I have a very different role than that. But at least in that particular context and with that particular teacher, I feel like I had that. It was like a day of Groundhog's Day. Like the next time I would show up, like, hey, so can you watch my class? It's like, no, I still can't watch your class, ma'am. But I guess for those who, have memory that sustains longer than that of a goldfish, what are some things that would be helpful or useful for those whose spaces you go into to do the service, for them to be an informed sort of partner in the work that you do?
I think it goes back to the collaboration. So being open and willing to, I'm not saying that we're going to come in and say, you need to completely redo your whole entire room, like take all the decorations down, move these, like, not that. We're not coming in to literally revamp and redo your life.
But we're not spies.
No, we are not spies.
Here that people think we will like report back to the family and I mean, don't get me wrong, there has been instances of like we had to, set very clear boundaries with staff, but we're not spies.
No.
Either.
And I think it's just the collaboration piece. So being willing to say, this is what I'm seeing, this is where I need help, but also it's okay to then, same point in time, put some boundaries in place with us too of like, that's not feasible for me to do in this setting. So we can be helpful with that. So I think it doesn't really matter who it is, where it is, as long as they're open to communicating with us. I think that's the first biggest thing.
I do think sometimes we have to work as clinicians to open that door. I know for
Absolutely.
I've learned that firsthand where maybe I didn't have those conversations at the start. And I think it's important to make sure that we are saying, hey, tell me if this doesn't work for you, whether that's the family or the school. I might have the best ideas ever, but if they don't work for you, that's all I care about at the end of the day. So we can come up with a different plan that will most likely work behaviorally, but it has to be feasible at the end of the day. So opening that door, allowing them to give us that feedback, and us not being punishing when they come to us and say, this isn't working. Well, what the heck? Why not? Aren't you doing it right? Us being open to hear that feedback and be receptive to that and say, yes, I hear you on that. Let me think about this.
I might not have an answer right then and there for you and how I can make this better. But going back and saying, let me think about it, think about your concerns, think about what's going to work for this kid, and we can talk about a plan that is more feasible or doable.
Sure.
Openness to that. And then on the flip side, for parents or schools, like on the flip side, probably what's been happening isn't going well. So there has to be some, again, like movement for both people. I can think of a couple different, I was always one of my assignments in grad school. If I had an idea, my mentor was like, now come up with 2 or 3 other alternatives to that, because this idea might not work or it might not be feasible. But yeah, if things haven't been going well, then I probably have some value to like give you ideas or something to try, because we all will often like we'll come up with our, no, that won't work. I tried that. I did that. I'm like, how did you do it? How? Even a very basic procedure like a timeout is often mishandled. People have their own ideas of what that should look like, but we're thinking this is like the behavioral way to do it. Is it easy? Probably not. Will you see some crap? Probably. But yeah, if you're getting a referral for our service, like things probably haven't been going well. So hopefully there's some openness on both sides too. Mm-hmm. Does family base say that? Let's do something different? Or there's one, I forget, one department that uses that. We got to do something different or we'll keep getting what we've been getting.
That's a big, often a very common part of the conversation in drug and alcohol work too. Like, your best thinking got you here. Like, and if we keep doing what we've always done, we're going to keep getting what we've always got. And it's so funny how like the therapist version of Kim like knows that so deeply and feels that. And then like the mom version or the wife version or like the other parts of myself where like the fact that we have a dog that just pees on our floor all the time. And like, he just gets so excited. And like, I know at the depths of my soul, I cannot make eye contact with him until he goes out in the morning. But he's so cute and fuzzy. So I make that eye contact. And every morning it starts out with like the chaos and the shenanigans of, a 2 working parent household with 2 little kids and 3 dogs, and someone pees on the floor. And like, sometimes it's the dog. But there's not always that. I guess I say that to say I have a lot of compassion for both sides of that coin. Like, as a provider, I'm always like, well, hey, we've done this exact same thing for the last 27 years and it's not worked, not even once. So could we maybe pivot? And then as a caregiver, I can very much see how one would get stuck in their ways and or just not be able to tolerate not listening to or ignore, like you use the example of like ignoring the child when they cry. I'm really good at that professionally. Personally, it's like, son, I need you to suffer silently today. Like, I don't know what it is. Stop yelling.
People's kids do things.
So my skill is I always have not AirPods, ear plugs in my fanny pack because it's a lot easier for me to do intentional ignoring when I'm not also triggered. So I just turn down the volume a little bit. My youngest can get very loud. So, you have to tap in support wherever you can get it. But I could see both sides of that coin working.
It brings up, sorry, I don't want to monopolize the conversation, but it brings up another great point and just a challenge of not many people understand how behavior works. So it's like a very simple concept, but and we don't really expect like the average parent or the average teacher to really have like an in-depth understanding. But even for basic things like, if we want to use a timeout effectively, we have to remove all the attention. Like, we can't be explaining things to them or sitting them in the chair where there's like the TV's on or sending them to their room where they have a host of goodies to play with. Like, just going from there, to if we are using planned ignoring, even reinforcing. Like I've been in classrooms and the teacher's like, well, I have a reward system. I said, okay, like, what's your system? She's like, at the end of the week, if they're good, they get to pick a prize. I'm like, my head's just spinning of like, okay, what is good? What are the prizes? What are the reasons they wouldn't get it? Like, there's so many things That's why I made my token economy training. Like, there's so many things that they're not public knowledge. We don't expect them to be, but like people are left baffled as to like why my system isn't working,
Why a 5-year-old doesn't wait until the very end of the week to be rewarded when it's not enough.
right? Like, what is good? Is anyone good all week? I don't think so.
Not
All week, every day. Like, so we come up against situations like that I don't believe people are ill-intentioned. Rarely. There might be a few, but I don't believe people are ill-intentioned. They're just ill-informed. And so like disseminating kind of some basics about behavior can go a really long way when people start to understand like, oh, I shouldn't have done that. And like, it's fine. You're human. We all do it. But like, so next time or pick your battles so you don't get in that situation again.
Is there anything in particular that y'all believe would be useful or helpful for a master's level provider, kind of either fresh out of graduate school or looking into like an MTBC or even a BCBA role? What are some things that maybe you wish you had known as that early career clinician, or that you believe would be useful or helpful to those maybe seeking employment in this area?
I think similar to the BHT role being a good stepping stone, being an MTBC helps also gauge like kids isn't it, or, problem behavior isn't it. Like maybe I've had staff before say to me, like, I just learned I don't like to go to the homes and I need a job that's more like clinic or outpatient focused instead of I don't want to walk into people's, private environments. So I think it still gives you enough of a variety of interactions to really decide like what parts do you like and what parts do you not like long term.
Yeah, I think you gain a lot of professional skills as well. I think it's one of those stepping stones that even if it's not something you want to do forever, whether it's BHT or BC, I think you're taking those skills on with you to your next, career path. And yeah, I think that.
I feel like that's a hard question for me to answer, because when I was an MTBC, I literally moved from a TSS role. I was an intern while I was getting my master's. And so like for me, it was kind of gradual how I was able to do it. So I felt like for me, I was set up for success in the MTBC role because a lot of my internship was kind of doing those things anyway. But I guess overall the support and finding like a good, with our supervision now, I think there is a really good support system there for that to really kind of help shape it up. But also it does take a lot of organization and independence. And we are mental health, so paperwork is heavy sometimes. Sure. And so I think not just the clinical pieces, but all the administrative pieces. I think that's where I see most of our newer staff struggle more, is not even necessarily the clinical skills. I feel confident in a lot of our newbies' clinical skills. I'm like, no, they have this. Like, I know they know what they're doing. But managing timelines and, be understanding that like, okay, well, I need, yes, ideally 3 observations at least for an FBA, but it shouldn't all be like the same location, or I'm always going to go 9 to 12. So like understanding kind of the more administrative pieces and scheduling. And while for me it makes sense and I understand that, I have a very difficult time teaching that to others because my brain just kind of, I guess I've been doing it so long, or I don't know. I'm able just to do it. So when someone struggles with like scheduling and doing this, I'm like, I'm a list person and I have like my schedule to me is like a puzzle. So it's like, it works. And so I have some neat areas there to teaching that skill. But I will say that's where I feel like a lot of our newer master's level clinicians really struggle, is with more that administrative piece than clinical.
Or even the soft skills, like how you say something to a family makes a it's sometimes that is a harder skill to teach too, but it's important coming in to be able to be flexible and a little less blunt in your communication sometimes.
Yeah, nonverbals.
I think learning how to juggle. And I think that's where Victoria spoke to, like, in IBHS, it does take a year to really, as a clinician, to figure out if this is for you, because you're juggling a lot of different pieces at first between learning the paperwork, figuring out the job, getting all your supervision pieces, and like there's a lot of different components. So I do think that is a learning curve at times, and that's where we're there to support. But I don't want people to come in thinking that they need to know it all, right? That's what we're here for, to help, to support and guide. But yes, we do need a very generally an independent person, but that is somebody who's willing to ask for help as well, or is willing to learn how to ask for help if that's not something they're good at. So.
Anything else left unsaid, or anything that I didn't ask that I should have, that would be helpful either to parents and caregivers who are starting to navigate an IBHS journey, to the system at large, so those where IBHS providers might find themselves within, or even when it comes down to those seeking employment or kind of looking at this thinking, this might be my next phase of career, that would be useful or helpful to individuals in that particular space.
Just a plug for PCS, I guess, would be, I think we do things well here in terms of offering support, whether it's supervision or the admin check-ins and additional things as we need. So I think we do offer a lot of very good scaffolding for new folks especially. I think we have a strong model. I mean, ABA is the base model for IBHS, which is the most research-based intervention for treatment of many behavior problems right now. So there's that, but there's also a lot of opportunities to grow, whether it's with us or another department. There's different certifications and licensures we can offer supervision for. So I think the feedback we get a lot from like managed care or even the state has been like, we do go above and beyond with a lot of things where we don't have to, but we like to kind of do more than what's expected.
Yeah.
That comes down to client care, but it also might be a pain in the butt for staff sometimes. But I think at the end of the day, most of our staff are like, yeah, I'm doing the right thing. I'm doing more. So, no regrets in terms of, did I try to help that kid? Did I do everything I could to help that? So I think we have a lot to offer, and we have a good program. I wish we had more people, more staff in the program so we could help more individuals. But I think we have a good thing going here, but it's a good service overall, and it's very, very needed, whether it's a PCS or somewhere else.
So as we close, would y'all, and maybe not, I didn't prepare you, so y'all might be like, no, Kim, I was not doing that. But I am curious about, each of you have been in this role now for longer than a minute. And we've talked about how like that first year is tough. It takes a minute before you really feel like you know what you're doing. You feel comfortable in the role, or at least don't feel like you're being waterboarded every day that you go to work. Why have y'all stuck in it for as long as you have? Or what is it about this role, this position, this service that's kind of captured your hearts and attention for longer than that year, or longer than that more short-term season, which it does tend to be. I'm not the only one that started in IBHS and then found myself in a very different type of service. And in my travels, I often I'll be in a drug and alcohol training and be like, oh, so who here started as a TSS? And like every hand goes up. Like everyone starts here, but y'all have stayed here. So what is it about this role, this position, this type of service that's really captured your hearts and kept you in it for as long as you have been?
So it's kind of funny you asked that. I think this is just kind of how things work. But I looked on my Facebook. You know how you can see the memories,
Yep.
right? I had a memory today that popped up when I must have been an MTBC. And it was something along the lines of, I just had a client go from being nonverbal to talking in sentences in 2 months. Hashtag ABA rocks, which that was like 12 years ago. And now this kid's like a teenager, and I don't know where he's at now. I wish I did. But he was literally one of those kids who was nonverbal, he would scream no. That was the only, so he wasn't technically nonverbal. He would just scream no.
He had one verbal.
Yes, he had one very loud verbal. But literally in 2 months. Now, it took a lot of, we were with him 40 hours a week. We were doing verbal behavior and, so we had a lot of things in place, but he was going from literally screaming no to doing simple sentences in 2 months. And that is huge. And like his mom, I still have their first Christmas card they gave me that year. And it had the sweetest message in it. It's in my home office. But I think knowing that, working through the difficulty, and like it was difficult when he was screaming. And I had to then, as an MTBC, talk to mom and say, hey, listen, like he's going to get uncomfortable. If you need to take a break, that's okay. But to then getting him to the point where he was able to talk and mom was able to like communicate with him. And I know the last time I talked to them was a few years ago. I ran into them someplace, but he was in the Boy Scouts and doing these great things. And I think that's what it was. He was selling like popcorn outside of like one of the stores, but he's doing great things. And so like, that's not typical. So like, let me just phrase, like, that's not a typical outcome of service, but knowing that you put the hard work in and you see those successes, but not just the success for him, the impact on his mom and dad and like grandparents, like seeing that was like more meaningful than him actually talking. Does that make sense? So seeing that and knowing like that's the kind of work that we do. It's difficult, but like we have some really great outcomes. And even now the administrative end of it, I don't get to see that as much. I see the kids when they come in for evals and they're like freaking adorable. But I hear what the clinicians do and I hear what they're doing. And so like hearing those positive things, doing quality calls and hearing how great our staff is and how much support they're providing, that means more to me than like anything else. So like, yeah, our data I think probably looks good. Our outcomes, we are data driven. We do great work, but knowing the positive impacts we have, I think that's where it's at. And I even had a BHT last week who's been here 10 years. We were doing an annual check-in and I was like, dude, what do I got to do to keep you here so I meet with you next year this time? And he's like, well, I'm just in it for the kids. And I think that's it. You have to genuinely be like find value in those kids and those families.
Doesn't mean you have to like them all the time.
Oh gosh, no.
Yes, you have to find value.
Gosh, no. There are days where I'm like, I never want to see another child again. And then I go the next day and I'm like, oh my God, you're so cute. So
no, I think that was perfectly said. I think seeing the changes on site make the biggest difference. And like Elise highlighted, that's not all the time and it's not every day. I think that's where sometimes it's hard, especially for the BHT role when they're in there every single day, in and day out. They don't always have the ability to zoom out and see, but look, we started here and look, we're here. So as an MTBC, I do try to share the data with them so that they can see those pieces and see the actual change, see the impact that you have on these kids. Because that's ultimately why we do this job, to make sure that there's functional gains with our kids and that we make a difference in their life and their client or the family's life. Because like Elise said, it's the diagnosis, the behaviors impact our client, but it goes so much more than that. And our kids' worlds, as they get older, get small. If they're restricted by behaviors when they get older, we all know what adult world looks like when you have a lot of problem behaviors going on. You're not taken into the community as much. You're not able to go out. So I think making those functional changes and seeing them and seeing the impact that we have is why I keep doing it. And then part 2 to that is these ladies. I don't know what I'd do on a bad day if I couldn't call one of them. So I think it's the coworkers support, the camaraderie. We've all been here for, like you said, longer than a minute now. So we know that we can call each other if needed. So I think it's 2 parts to me.
that is true. But I think we're a little bit unusual in the fact that at least us 3, and we do reach, I mean, they talk to you more than I get a chance to talk to you. But I think sometimes I talk to Sam and Alicia more than I talk to my spouse sometimes.
It depends on the week.
Right. Yeah. So like it's a second family.
It really is. Yeah.
And I think even outside of the impact you see in the kids coming into like the clinical director role now, I love to see that growth in the staff. Like you started and you felt like you had no clue what you were doing with all these kids running around with all these behaviors. And then I get to say like, but you did that. Like you learned this new intervention or this new skill, or you made a lot of growth with a family that hated you when you started. All those pieces are also great as a supervisor, just to get satisfaction out of, you know, their own growth and their own progress as a human.
Where we had a BC who used to always raise her hand.
Thinking of
When she first transitioned from a PhD to a MTBC, she was so timid, and she would like literally raise her hand in like our weekly meetings. And I was like, why are you raising your hand? We don't raise our hands here.
hive and doth.
Yeah. That's not how we function here. But it's so funny. And then she comes to the meeting last week and she's like, guys, you're going to be so proud of me. I did this week. And I was like, see? And I was like, it's just amazing to see that growth. And I'm like, I am really proud of you for doing that. So yeah, that is true. We do have some really great staff that make some really great gains.
Well, funny. Yeah, I've supervised these three in some capacity. So it's definitely, I know I've said it at your like annual check-ins. I'm like, it's very satisfying to me to see like growth like from the ground up. And we have had like overall, I think, very good outcomes promoting from within. I think it just tends to go well because I think we have that pretty good system of support and an opportunity there. So there's that. Having a good team around you definitely makes the job, I mean, easier on one level, but more enjoyable, and you know the quality is good. The other part, yeah, is definitely the kids and the families, because we're there for the client, their name's on everything, but we're also there for the moms and dads or the teachers who are having rough days. And sometimes we're the therapists for them, and we're reassuring them like it's a bad day, not a bad life, or like it's okay. You did this thing, like you're human. Kind of looking ahead to that. I've, had a couple kids I've worked with for longer term at this point and seen them grow up. See some of the things where we used to do like timeouts, or we were doing discrete trial training to get them to learn the letters, and now we're preparing for employment. And one of my clients loves to go to the beach, so he writes his list of items he's taking and packing in his suitcase. Like just little stuff like that is really gratifying to me. And the one time I asked a mom, and like I didn't mean this to upset her. I don't know if I did, but her response was really impactful. And I said, "Where do you think your son would be, had you not chosen ABA? Like where, skill wise, what would have you gone, or what direction do you think?" And she just said, "I don't know. I don't like to think about it." And so it like made me feel good, but also a little bad in the moment. But I think it made such a difference for them that was kind of the only option. And of course, I love the evidence-based research foundation of ABA and the usability. When in grad school, I always planned to go for clinical psych. That was always my plan. And then I got a call from one of the professors when I was still doing undergrad. They're like, "Hey, if you have room in your schedule, why don't you come to this?" It was a ethics class taught by Dr. Fox at that time. And I'm like, all right, whatever. I have, I only had 9 credits, so I took it. And that drew me in. And I'm like, yes, this is the thing for me. Like it made so much sense to me. But I really love the usability of it, whether it's work or home or out at Target and you see something going on. So lots of good things.
Well, thank you all. Thank you for spending your Monday before Thanksgiving here to, I'm sure you have 1,005 things to do. So I really appreciate you joining me for this particular series, which is all about just sort of demystifying the levels of care and better understanding what services are available. We do have, I believe, 2 more in this rotation. So we're going to look at outpatient therapy. We're also going to look at drug and alcohol therapy. In the new year, we plan to start a series that looks all at relationships. So how we are our best friend or worst enemy in the most important relationships within our life. And so really looking forward to taking the How to Be Happy Hour that direction. But otherwise, thank you all so much for listening. And we will catch you next time.